I'm going to welcome Dr. Don Neese to talk about why chronic disease. Dr. Neese has an impressive list of credentials which are published in your book, and I'm not going to go through them. I know him best as the director of another practice-based research network consortium in Colorado called SNOCAP, and Don told me that he would like to simply be introduced as a friend of Ren. So Don, please come up and welcome.
It's great to be here in Wisconsin with Ren. Not my first time in Wisconsin with Ren. Got to be here a while back, a little over a year ago, with our INSTTEP projects. I want to give a shout out to folks from Iron River. Do we have anybody from Iron River here? No? How about Toma? I know there's Toma people here. Hi, Toma. Richland Center? All right, great, great. And Milwaukee? Good deal. Okay, well, I'm an old guy, but I still do some young social media stuff too. So I created a hashtag for the meeting. So you can, who all tweets? Do we have any? Okay, hashtag RenConvocation. All right. A few of us were at the PCORI meeting last week in Washington, D.C., and oh my gosh, the Twitterverse was full of tweets, both from patients, researchers, community members. It was really a lot of fun to see all that. So maybe we can equal some of what happened with that. So I said it was fun for me to be here in Wisconsin with Ren. Ren, I don't know if you guys realize this, but Ren as a practice-based research network is really a national leader. We certainly look to Ren for leadership from Colorado. You guys have been on the forefront of practice-based research for a long, long time. And when I had more hair, and I was starting out my career as a family doc and somebody that was interested in doing research. One of our big national research meetings in primary care is called NAPCRAG. And you know, I was starting out and I was giving talks, and this guy would come, and he would come to all my talks, and he would sit in the front row and he would make these great comments. I was like, who is this guy? I've got to get to know him. Well, it was David Hahn. So it's really, really great to be here. And we're going to talk about chronic conditions. So why chronic conditions? I mean, it's obvious, right? Okay? Come on, David. But we're going to go through some different perspectives on this. We'll start off by talking about, so what's the overall burden of chronic illness? You know, we are going to look at this from a few different sides, from the financial aspects, what it costs to treat chronic illness. We'll talk a little bit about, you know, what's chronic illness really mean to patients. That's a really important thing to consider. I know we have patients here with us, and maybe we can get some of your perspectives. What's the benefit if we actually start to addressing chronic illness in a comprehensive way, both at the practice and community level? And then, what's PBRN good for? What's REN good for? What's SNOCAP good for in this space? We'll talk a little bit about that. Okay, everybody on the right flight? Good. Okay, so chronic disease. You know, nobody likes to be told that they've got something chronic. It sounds kind of terminal. And I've certainly heard that from patients. They don't tell me that in the office, usually, but when we get patients together for something we call boot camp translation, which I'll talk a little bit about in a few minutes, they use some pretty dramatic language to talk about, you know, when I or my colleagues When we tell somebody that they've got a chronic illness, that's a big deal. So, you know, we kind of joke about it on the cartoon here, but this is serious stuff. So just some numbers. Probably, you know, if we took a poll, probably a little more than half of us here in the room have some sort of a chronic illness. They're very common, and once you get age 65 or older, it really goes up pretty dramatically. So something that is huge in terms of numbers. I know over my career, how that's kind of chronic illness is represented as a part of my practice has gone way up. It's a huge, huge part. You know, if I look down my schedule, most of what I'm seeing folks for are, you know, follow-up on chronic conditions these days. 75%, 3/4 of healthcare expenditures. So that's pretty huge as well. Well, when I was preparing this talk, I went looking to see if I could find some data that I hadn't seen before on chronic illness. And I found this Milken report. This is a report that was originally produced back in 2003. It's got some neat aspects to it because not only did they just kind of try to look at some of the costs of treating chronic illness, they tried to look at overall burden. As we'll see, they looked at some unusual aspects of this, and they also tried to make some projections. So, you know, if we don't do anything, what's the trend line going to look like? If we try to work on this really hard, what might we be able to impact? So we'll get into some of that. But first off, just, you know, here's a map of the US, and I don't know, it's kind of a little bit of a red-blue state thing going on here. So Wisconsin, you can see, is green, so not quite in the top tier, but better than most. But listing of some prevalences of chronic illness here, and you'll see that, so cancer is represented here, 3.7% of the total population with cancer, 4.9% with diabetes. Heart disease, 6.8%. Hypertension, that's a higher number at 13%. All the way down to pulmonary conditions of 17.4%. And again, this is 2003 data. Well, what about Wisconsin? So if we look at Wisconsin numbers, the percentiles actually mirror the national data pretty well, except for in the area of behavioral health, mental disorders, higher here in Wisconsin than the national trends, but everything else tracks pretty closely to that. And this just breaks out the economic impact in Wisconsin. Again, 2003, total cost, $26.4 billion with a B. So that's pretty darn huge. If you look at the pie chart there, the small quarter slice, that's just the treatment expenditures. The rest is lost productivity. Okay, so those were the old numbers. Let's look at the more recent data. So they went back about a year ago, a little over a year ago, and did a checkup. Okay, it's checkup time. Been working on this, maybe trying to work on it for a little over 10 years. How far have we gotten? What do you guys think? Did we do a good job? No, somebody back there is going, yeah, okay. So, you're not looking ahead, are you? So, here's where this trend line stuff comes in. So I have to explain this a little bit. So the green bars here are if you compared the actual expenditures to what they were projecting this should look like if not much really changed, okay? And the blue bars are if we went to work on this and we made some changes and we really tried to address things, where did they project we might be? So you can see in terms of treatment expenditures on the left, the green bar, well, we've actually done worse than they were projecting, and a lot worse than they projected if we would have done, had we really kind of tried to focus on this, to the tune of $28 billion. And then indirect impacts, again, huge loss in productivity when you look at what we might have accomplished. So, you know, when we get to overall total economic burden, you know, $135 billion that have been spent needlessly. And this slide is interesting because it speaks to the fact that we're not doing a good job of prevention here, okay? So preventing people from developing chronic illness. So this reflects the growth trends. And you notice, you know, across the board here, everything's going up: cancer, diabetes, hypertension, stroke. The only thing where we've made a good impact is in heart disease. So that's actually gone down a little bit. So those are the numbers. This is a photograph from my front porch in Denver, get to look at of an evening. So what are the possible benefits if we really went to work on this and brought all of our stuff to bear? Well, this is a slide about, you know, what the impacts might be in Wisconsin. Again, just focusing on the number of cases. So what might we be able to present? And I'm not going to run through the individual ones here, but, you know, the ones where we have the potential to have a big impact: pulmonary conditions, hypertension, heart disease, and mental health. And again, this slide just speaks to, again, the potential impacts if we were to address things on a cost basis. And again, the thing that stands out to me every time I look at this is that loss in productivity. Well, patients. What do patients think about this? So these are a couple pictures from a couple of advisory boards that we work with in our PBRNs in Colorado. The top one is the Community Advisory Council of the High Plains Research Network that's run by Jack Westfall and Linda Zittelman. And the lower one here is the Patient Advisory Council for our CareNet practice-based research network. Because SNOCAP is a consortium of networks, so we've got several that we run. So we talk to patients a lot, try to find out what they're thinking about these things. And you know, just from a numbers standpoint, I've also pulled this out of the Milken report, just to give an idea, you know, things that matter to patients that they actually tracked. So life expectancy, again, this is looking at their baseline projections versus the optimistic, what kind of an impact we could have in terms of life expectancy. And then this next one, one that I never think about, but what's the impact of chronic disease on education? This graph here is actually looking at percentage of the total population 25 years and over with a bachelor's degree or higher. I've never thought about the impact of chronic illness on whether or not people are getting higher education. But, you know, once you start to think about it, you know, those financial things add up, you know. Is somebody healthy enough to go to class? If they're depending on family finances, it's I mean, my kids depended on my family finances to go to college, and, you know, if you're suffering from a chronic illness, those resources may not be there. So something else that I thought, at least in the national data from the Milken report, that is significant to our patients. So here's some quotes that our patients have told us in Colorado, diabetes, it felt like a death sentence. So this was one of our patients when we were doing a boot camp translation on self-management and diabetes, and she was talking about when the doctor said, "You've got diabetes," and the impact of that statement, and thinking about family members that had diabetes, all of that. The second quote, "Chronic illnesses don't just affect patients." Yeah, so affects family members, caregivers, lots of other folks. And I love this, our culture is based on quick fixes, but for this, there is no easy way out. It's no easy fix to this. And the poster there is something that one of our urban Latino boot camp translation groups came up with around blood pressure and the fact that high blood pressure is silent but deadly. You might not know you have it, but it can have a huge impact if you don't take care of it. Another thing that I thought would be worth taking a look at is, so it's kind of unusual in my practice anyway. If somebody's got one chronic illness, they've probably got another. Multimorbidity, how does that impact things? So it's not just the burden of one particular chronic illness. That's kind of oftentimes what the research focuses on. But what's having multiple look at? So this is a paper from the UK, but I think it speaks to things that are relevant here in the US as well. So this was a study of illness perceptions and how it impacted whether or not patients could engage in self-management behaviors. So, you know, things that folks do in their daily lives to take care of themselves if they've got a chronic illness. That's what we mean by self-management. So that kind of caretaking behavior was strongly predicted by how people felt about their chronic illness and its impacts. So, you know, that statement of diabetes feeling like a death sentence, that probably, when she was in that mode, had a huge impact on her ability to take care of herself. Self-monitoring and insight was also predicted by hassles in healthcare. And the next slide, I'm going to tell you what hassles are. Health status, so does somebody feel like they're doing well in terms of their health? Predicted by age, that one's pretty obvious, but also this kind of subjective experience of what it means to have more than one chronic illness. So again, big impacts that come into play. So what are hassles? And this, I think, begins to transition us into what's a PBRN good for, okay? So the hassles, this was done by another one of our PBRN colleagues on the national stage, Michael Parchman, who's now at the McCall Institute, works very closely with L.J. Fagnan. But this was work that was done when he was in Texas. And what they did was they asked patients about, you know, what their experience of healthcare was, and then looked at how that impacted how they were doing. So hassles were lack of information about my medical education. That's a hassle. Lack of information about treatment options. That's a hassle. Lack of information about why I've got 10 different medications on my medication list. You know, what's that all about? So information, lack of information, huge thing. Problems getting my medications refilled on time. That's a big deal, yeah. Now that, for most folks with chronic illness, they're having to do mail order. Boy, I hear about hassles with that all the time. Uncertainty about when or how to take my medication, side effects, another lack of information. Why have I been referred to a specialist? Having to wait a long time to get an appointment, poor communication between different doctors or clinics. EMRs have fixed that, right? No. Lack of information about why I need labs or x-rays. Lack of time to discuss all my problems during scheduled appointments. Wow, that's a tough one. Having my concerns ignored or overlooked by my healthcare providers. So their findings were, after they controlled for the patient characteristics, so age, demographics, what their specific conditions were, they found that if these hassle factors were lower, that tended to be associated with improved primary care. So if primary care was working well, the communication stuff was happening, those hassles were much lower. So what's PBRN good for? How can we work on this together? So this is a picture, again, of my patient advisory council folks that are presenting a poster at our SNOCAP convocation a few years back. So PBRNs have, I think, some characteristics that make them especially well suited to this kind of topic and working on this. So PBRNs by their nature are participatory. The genesis of PBRNs was folks really kind of saying, we want to participate in the creation of the knowledge and the evidence that we're applying in our practices. They're engaging. And I heard a great quote about a month ago about what's engagement. And it was about contrasting engagement from what we typically do in the lofty academic center of the university. We talk a lot about outreach. We're going to outreach to Lyman, Colorado. And so the guy that told me this, he's the vice president for engagement, which I think is such a cool title, that a university has a vice president for engagement. This is our good friends to the north, Colorado State University. So Lou Swanson, he's the VP for engagement, and he said, the difference between outreach and engagement is outreach starts with an answer. Engagement ends with an answer. Outreach starts with an answer. We've got the answer. We know what you need out there in Oshkosh, Wisconsin. Engagement says, no, we've got some ideas, we've got some expertise to bring to the table, but you guys have just as much expertise. And that is, I think, so foundational to PBRNs, which, again, that inclusive nature. PBRNs are good at getting stuff done. We are masters of doing lots of things on a shoestring. So I think that's also a feature. And PBRNs are enormous catalysts. One of the things I hear when we have our convocation in Colorado is folks come up to me all during the conference and talk about how participating in projects affected their practice, not just in terms of that single project and what they were doing, but it changes how that practice actually works. And I think that there's spread of that. I think states where we've seen a strong history of PBRN work, I think are states where things look different from a primary care practice level. So chronic care model, this is from Ed Wagner at the McCall Institute. And, there's all this stuff up here. And, it's kind of almost like in the cloud when this was created. I don't think anybody knew what the cloud was. But, I think where our PBRN sweet spot is that area that I've circled in red. So working on self-management support and really kind of these productive interactions that lead to improved outcomes. Yes, we do some decision support stuff. Yes, I've done clinical information, technology research, but really I think our sweet spot is down in that lower part. And this is what we don't want to be doing. This is a slide from my friend Jack Westfall. He says this is the Lyman Police Department. Now, Jack used to work in Lyman. He probably knows these guys, but he said, I have no idea what they were doing here. But we do not want to be pointing the fire hose in the wrong direction. So that's why that engagement piece is really important. So these are some of the folks that we work with. I mentioned our Patient Advisory Council for CareNet, Community Advisory Council for High Plains Research Network, the INSTTEP project that Ren participated in, and right now we're engaged with this big hairy Evidence Now Southwest project where we're also engaging patients and practices to help us figure out how to do this. So this is a boot camp translation kickoff from Portland, Oregon, because Orpern also participated with us in this. And boot camp translation is all about trying to get our stakeholders to the table, our patients, our practices, and with INSTTEP we did a new twist on boot camp translation, because typically what we do is we run this mainly with community members or mainly with patients or what we call free-range humans. Because believe me, there's religious wars about what's the difference between community engagement and patient engagement. So we call them free-range humans. And with INSTTEP, though, we intentionally brought practice. We said, okay, we're going to recruit 4 practices from each network, and we want you to bring your patients to the table. And great conversations resulted. And in SNOCAP, this was around self-management for chronic disease, and it was about translating the tools from the AHRQ self-management toolkit that this big federal agency had put together. They didn't like any of those. In no state did they like any of that stuff. They said, we want to make our own. We're going to grab this from this one, this one, this one, and let's do this. So this one that they put together, take charge of your health. So our patients and practices told us, patients, they really don't understand what this is all about. If we could make a flyer that we could hand out to patients while they're waiting to see the doc that would kind of spell this out for them, help them to think about this. And they really thought, goal setting. Well, that's not moving your hemoglobin A1C from 8 to 7. What's that? That's just a freaking number, okay? We want goal setting that is, I want to be able to take a walk at night without being short of breath. My grandkids, they're taking a trip to Disney World. I'd love to be able to go with them. Those are goals that are meaningful. So this was a different kind of productive interaction. And man, our patients have so much expertise to offer. And when you get people around that table, I think those of us that have letters behind our names listen differently. Really, really cool. So we actually saw, here's some research numbers. We saw good impacts in terms of process of care. Patients felt like they were being more listened to, that they were being involved in setting goals. And the bottom one here, which I think is the coolest, is that, and we just measured these folks over 3 months, but over 3 months they felt like they were actually seeing improvements in their own self-reported health. So if you want to learn more about bootcamp translation, that's our website, bootcamptranslation.org. And I'll stop and see if there are questions or discussion if we have time. All right.
Yes, we do. We do. Please, let's give them a big hand. Yeah, we have time for questions. So there are microphones are spaced around the room. So if you want to come up and ask a question.
Yeah, don't be Presbyterians. Come on.
While we're waiting, I just wanted to thank Don for hitting a lot of high points. And during the talk, I was thinking about a patient of mine who you talk about attitude being so important to management. She had a problem list as long as your arm. You would have thought she was dead with all this stuff. Yet she was so vital and active and positive. I would take her to my sessions with first and second year medical students to give them an idea of the difference between medical disease diagnoses and how people can manage their conditions. And I think that to me illustrates the difference between what I call disease-oriented thinking and patient-oriented thinking. You know, the A1Cs, the problem list, and then what are people really doing and how are they feeling and acting?
Yeah, that's a great story. Patients are so much more than their problem list.
I see a hand raised in the back. There we go.
I wanted to make one comment on the chronic disease model, because the thing which has always bothered me about that diagram is it doesn't show the patient having an individual relationship with some other individual healer or caregiver, and that might be a nurse practitioner, a physician, a PA. And I really do think that there should be somebody to whom the patient really knows and who really knows the patient.
Yeah, thanks, John. That's so important. The healing aspect of relationships that we have with folks, I think, is so important. And you know, it reminds me of something that came up last night, where you know, as we start to work with our patients, you know, even at the practice level, you know, the healing relationship goes both ways. You know, I think every patient that I've engaged in this way, they are so interested in helping us to do better, helping us improve our practices. And so it can be such a great two-way exchange.
Hi. Thanks, John. That was a great overview. This is Val Gilchrist from University of Wisconsin. Hi. Don, can you talk a little bit? I really resonated with the slide you showed about the informational needs of patients, whether it be medication or prognosis or whatever. Can you talk a little bit about what you may have or have not learned from your patients, your advisory groups, about how they like to receive information? I mean, most of us have tried everything from APPs to groups to online to written material, and what kind of help you might give us, because it's really hard to incorporate that in our practices.
Yeah, thanks, Val. Great question. And as you were asking that, I could hear Jim Smith's voice in my ear, who's part of our CareNet Patient Advisory Council, because we've talked a lot about this. And what Jim has said repeatedly, and it's been echoed by some of the other patients, but Jim's this thoughtful, retired Denver city bus driver. And he's done a lot of other things too, but great guy. And Jim says, you know, Don, we know that you guys have a limited amount of time. We get that. And you know, what really matters to us, and we know you don't have time to tell us everything, but if you can set the stage and then make the handoff to you know, your nurse or your medical assistant or somebody else that can then close the loop on that, or a care manager. You know, we've talked a lot with them about, you know, how we're starting to bring care management into that space. So, and I've heard that repeatedly. So I think what I've heard is that patients still want to have that personal relationship with their doc or their clinician, but they recognize that, you know, we've got a team, and they understand that we're in a kind of a team mode for that. Yeah.
Paul Trader from Oshkosh, and I work in NENA. You know, hardly anybody pays all of their own costs for healthcare. So we're engaged with, we interact with various payers, and one barrier to good management of their care is rules that the payer has, such as for refills. Some places will not allow a refill even 1 day early. You know, it's like exactly 30 days. That doesn't always work out. Is there any attempt to engage payers for health care to help solve this problem?
Yeah, great question. Payers. Wish Jack Westfall was here for this question. So for those of you that don't know Jack kind of joined the dark side. He went and took a position as a chief medical officer for a payer, but it's a co-op payer. So the Affordable Care Act, you know, created these, or